Good morning, and as of last night, we lit the holiday tree here on campus, so officially happy holidays. Please, if you are at the buffet, proceed to get your breakfast and find your seat, but in order to keep us on time, we will go ahead and get started. So I'm Valerie Johnston. I am a member of the faculty at the Neely School of Business, and I'd like to welcome you to this, our annual healthcare forum. So this forum allows us to do a lot of things, but two that I'd like to make note of today. One is just to provoke conversation about topics that are important at the intersection of business and medicine, and I think our topic today is one of those. And secondly, to showcase what here at TCU's campus is a vibrant set of cross-campus collaborations, this one in particular between the Neely School of Business and the TCU and UNT Health Science Center School of Medicine. Multidisciplinary perspectives and leadership are fairly critical for us in shaping the future of our healthcare system, and so hopefully we will role model that just a bit with our work here at this forum. So thank you for being here. I do want to give a special thanks to our forum sponsor, Mutual of Omaha Bank, whose support helped us to gather here today, so thank you. So in the Neely School in particular, we offer an MBA for healthcare professionals, and in that program, we really aspire to develop leaders who can help to transform our healthcare system across all sectors. And we do that with a promise. We do that under the guide of the Neely Promise, which is our commitment to unleash human potential with leadership at our core and innovation in our spirit. And so it's really my distinct honor today to introduce you, the DFW healthcare community, to Dean Daniel Pullen, who will serve as one of our moderators. So, and because this is his first time in front of this crowd, I'll tell you a little bit about Dean Pullen. So Daniel Pullen is the John V. Roach Dean of the Neely School of Business at TCU, and he's a professor of entrepreneurship and innovation. He's responsible for enhancing the profile of the undergraduate and graduate programs at Neely to maintain the school's upward trajectory. He also serves as a steward to TCU and the business community partners and focuses on defining and cultivating academic excellence and enhancing the diversity and inclusion initiatives. He came to TCU just in May of this year from the University of Oklahoma, where he was the Dean of the Price College of Business since 2014. So I won't read you his long list of accomplishments, but just a couple of highlights. He's won awards for teaching, innovation in business, and academic integrity, and was honored as one of Oklahoma City's 40 under 40. Prior to joining OU, he worked for the global consultancy McKinsey & Company, and a private equity firm of Hicks, Muse, Tate, and First, and its set of portfolio companies. His undergraduate degree is from the University of Oklahoma. He holds an MBA from Harvard Business School, before returning back to Oklahoma to earn his Juris Doctor. So, welcome, Dean Pullen.
Thank you, Valerie. And just before we get started, I wanted to introduce you to our panel. I'm Judy Burness with the TCU and UNT-HSC School of Medicine, and we're very excited to be here and part of this forum and joining with our friends at Neely. The School of Medicine has its first class. We started in July. We have 60 students. There's a few of you in here. Woo-hoo. I see some. But let me go ahead and get our panelists introduced. Next to Dean Pullen is Yvonne Kaplan-Lish. She is our Assistant Dean for Narrative Reflection and Patient Communication at the TCU and UNT-HSC School of Medicine. She has really big business cards to fit all that on there. Yvonne is a former journalist with a journalism degree from Northwestern. Then she decided medicine was in her passion, so she went back to medical school. She earned an MD from Mount Sinai, practiced as a pediatrician, and then really wanted to put those two things together. So she became the founding medical program coordinator at the Alan Aldous Center for Communicating Science, where she could really combine those two, and has educated physicians across the country in being better communicators. Now she's embedded in our medical school, and it's really a great partnership. Next to Yvonne is Ben Isger. Ben heads up PwC's Health Research Institute, and Ben gives businesses and healthcare advice and analysis and insight into what the trends are about healthcare alignment, about the future of medicine, and is a sought-after speaker on all of those issues. He has a master's degree in business administration from the LBG School of Public Affairs. Sorry, I was close.
I just got one, thank you.
And then our third guest is Wenji Tang Mao, and she is the Senior Executive Vice President and Chief Experience Officer for THR, where she's been for more than 20 years. And she is a recognized leader in innovative healthcare and technology. She has been recognized as one of the top women leaders in health and health systems, and one to watch. And then finally, last but not least, my boss, Dean Stuart Flynn, who is the founding dean of our TCU and UNTHSC School of Medicine. He also founded the University of Arizona College of Medicine in Phoenix. So this is his second new school. He came here really with the vision to train empathetic scholars, and that's what we're doing at our school. He is a graduate of the University of Michigan Medical School, where he does residency and then a fellowship in oncologic pathology at Stanford. So now you get to hear from these amazing folks. So thank you very much.
All right, well, I'll go ahead and kick it off. And I think Dr. Johnson did a great job of kind of framing the opportunity. I think this is the fourth year that we've been doing this, and it's just a growing and strengthening collaboration that really, I think, expresses the best of not only TCU, but the broader community and partnerships that we serve. And so it's a real honor to be a part of it for the first time. As I think about the importance of the topic, and as a business person, you just need to kind of look at the magnitude of this industry. It's rapidly becoming the largest industry in our nation, and it's in terms of GDP, and yet at the same time, this country is paying more per healthcare outcome than really any other industrialized nation in the world, which means that the business of healthcare is not necessarily just a science challenge or a patient care challenge, but the implications of science and patient care on the broader economy and what we pay for effective and efficient healthcare. And so it's really just as much a business problem as it is anything else. And we have a business model that many would argue isn't really returning value for money at least at the level of many of our peer nations. And so I'm really excited to think about the business challenges of this and how can we drive effective and efficient outcomes for our citizenry. And even in crass business terms, the reality of it is if you can't afford proper care, if you can't get access to proper care, then you actually can't be your own best self. If you're too sick to go to work, you can't get up, you can't drive the economy, you can't hold down a job, you can't provide for families that provide such a rich tapestry of strong communities, and on and on and on. And so we really have to have a forward emphasis on the business side of healthcare, and that's why I'm just so proud that the Neely School here at TCU is boldly leading nationally through amazing educational programs like the Healthcare MBA and this amazing partnership that we have with the medical school, and on and on and on. So it's a great opportunity to be here. I'm looking forward to participating. I'm looking forward to learning, and then collectively doing all we can to make sure that our citizenry gets the value and the outcomes that they deserve. I know Dean Flynn has a lot of perspectives on this. I don't know if you want to talk maybe about the patient side of this and its impact on the bottom line, but it's probably a pretty good jumping off point for our conversation.
Well, thank you, Daniel. First of all, I want to welcome everybody, and something I always forget to do at the end, so I'm going to remember to do it at the beginning. I want to thank everybody who has worked so hard behind the scenes to put today together for us. I will tell you a little dirty secret in the training of physicians, and that is most of us did not grow up with any appreciation, understanding, education in the business side of healthcare. So that was somebody else's concern. Our concern was to treat and heal. And I will tell you, we have some of our medical students in the audience today. They absolutely, in their four-year curriculum, will have the beginning of their understanding of healthcare economics and the business of healthcare. So Daniel mentioned that patient satisfaction, the patient experience. What this panel is going to do over the next few minutes is kind of weave the story, which we all live as patients, what your satisfaction has to do with the bottom line, both business-wise, but also for your health. So just some background information. Patient satisfaction affects clinical outcomes, patient retention, and medical malpractice claims. That is one thing that we've come to appreciate over the years. If your patients respect you, you can make a mistake, you own it, and it doesn't automatically then end up in a malpractice. But you can see that's a relationship. It affects timely, efficient, and patient-centered delivery of care. Kind of to this end, patients are demanding a bigger role in their health care. We're all sitting here as patients. We don't now want to just be told what to do. We want to play a role in what is happening to us and how health care is being delivered to us. So one of the measures, and I'm going to allow my colleagues to explain this, are Press-Ganey scores. So the Press-Ganey recently reported that hospitals with patient satisfaction in the 90th percentile experienced nearly a 1/3 increase in patient volume, or an additional average of 1,300 patients per year. So again, that's great for the patients. It's also great for the business model for those institutions. I won't give you the data on those that score in the bottom 10%, but you can imagine it's kind of the polar opposite. And it's not just the business side, which I addressed earlier. So in one of our big journals, Academic Medicine, it's been studied and reported, patients who trust their doctors have better clinical outcomes. In simple terms, this means that the effectiveness of treatment depends on how much patients trust their physicians. So with that as a jumping off, Ben, I'd like to ask you the first question. You spend much of your time looking at these questions about what drives patients and providers. What are the patients, from your perspective, actually looking for in terms of a better experience?
Yeah, thank you. Just when we think about patient experience, even taking a step back, why has this become so important? And I think we've started to allude to that. But one thing is consumers are paying more out of pocket, so they expect more. So if we look over the past decade, we've seen premiums have increased about 200%, or the deductibles, I should say, for consumers have increased about 200% over the last decade. So they're paying more out of pocket, and they expect more. The second thing that we see is that people are getting used to how other areas of the economy work, right? So when you want to book travel or deal with your financial institution, it's right there at your fingertips, and you can get the information typically that you want very quickly. You can book things, you can check things, you can do things instantly. And people now want that same type of experience in the healthcare world. And the third thing is there's actually a lot of non-traditional healthcare companies that are entering the space, and they're saying, we're going to fill the gaps and create a great experience for you. And the reason is because, as we alluded to at the beginning, healthcare is 18% of our GDP in the United States. About 85% of our Fortune 50 companies are in healthcare in some way. And take it down from the Fortune 50 all the way to the smallest app maker working in a garage somewhere. The majority of apps out on the Apple Store are healthcare related. So it's a huge part of the economy, and non-traditional companies, technology companies and companies that work in hospitality are entering the space and saying we can help provide a better experience. So that's kind of the backdrop of what's pushing some of this for consumers, which Dr. Flynn talked about. And if you do a good job with that, then the result is, well, you're going to have more people, more happy people, and have better business outcomes. But there's a little cautionary tale here when you start to mix the clinical with the business world. and that is it's not quite like buying an iPhone. There is a lot of differences there. And so one of the things that you see is kind of a lot of challenges around how you even get at consumer sentiment. So if you go out and you survey consumers and you try to figure out what they want, there's going to be a very big difference in terms of how someone experiences the healthcare system if they're generally young and healthy and they just need to go into a retail health clinic every once in a while when they get sick, versus someone who's got a terminal cancer diagnosis, versus someone who may be frail elderly and is taking up to 30 prescriptions a year and is going to the doctor's office or the emergency room multiple times a year. So there's a lot of difference in terms of how people experience it. And so you may see some consumer segmentation in some consumer surveys that say, well, really what people want is just convenience and it can all be done through virtual health. And that's correct. That can be a solution. It's a very business-oriented solution to it. But that's not necessarily how people are going to react to the system if they need a lot more care. So what that means is we really have to look at what are the future consumer experience points. And that's where we've seen the biggest change, where 10 years ago, a lot of hospitals, health systems, physician practices, it was all about what I call the very physical aspects of experience. It was every hospital now has valet parking, and we've got better food, and we've got nicer rooms and flat screen TVs. And that's kind of table stakes now. Now the next level of consumer experience is how can we help you navigate the billing issues? How can we help you understand how much you're going to pay? How can we help you navigate all of your treatment options? And that stuff is very complicated because that requires a lot of different physicians to connect together and talk together. Now they don't want to know just about will the prescription drug help my issue, but what are the side effects of that prescription drug? That's important to me. So we've now moved into this world of much more kind of complicated work to do when it comes to consumer experience.
Yeah, I want to build on that. We talked a lot about experience and consumer sentiment, and that's giving rise to these amazing CEO leadership roles, namely the Chief Experience Officer role. So Wenji, you are the CEO, Chief Experience Officer. Tell us about that role, why it's important, and sort of how do you really get into the mindset of your customers?
Sure. So first of all, CXO, not CEO. Barclay might take a little bit of to that. But no, it's everything that Ben just said, except how do we do it in this community? Because what consumers want in Dallas-Fort Worth, right, is different. How we buy, how we shop, how we make decisions is different here than it is in New York, or we were talking about California earlier this morning. What we need is different in this community. So my role is to really deeply understand on an individual and personal level what it is that people in this community need in order for health not to be a barrier to living their best life. And then marshal the resources across Texas Health and develop a strategy, new capabilities, products and services that deliver on that promise. And so for Texas Health, that's a pretty big transformation, right? If you think about who we have been historically, we've been a traditional provider organization, primarily episodic sick care. But as Ben mentioned, consumers in general, right? We don't want a transactional experience anymore. Where you find differentiation and can really build value, and from an organizational standpoint, is in that long-term loyalty and earning the trust and lifetime loyalty of a consumer versus a transactional experience every time I need care or need something. So making that switch of really understanding that long-term loyalty, what drives that, and what are how we need to change how we deliver the care we currently have, and what are new things we need to offer in order to have that entire health continuum covered so that we truly walk that journey with you. That is really my role, and many, whether they're called chief experience officers or chief transformation officers, they're kind of similar and interchangeable, but that's the role. So within my purview of strategy, consumer insights, product development, data and analytics, patient experience, how does all that tie together? Digital health, how does all that tie together to do exactly what Ben said, which is navigate you in a personalized, curated way to help you meet your needs, whatever that is. Whatever it is, when you say, how does health impact your ability to live your best life? We can better understand that and know how to support you through that journey.
So I just want to highlight what, when Judy introduced Yvonne, to tell you how phenomenally fortunate the medical school in this community is to have Yvonne and her team. We stole her, which is a harsh word, from the Alan Alda Center, but with his permission, just to be perfectly clear, to come here to Fort Worth. And we're the first medical school in the country that really is focused on training our young physicians to be on how to communicate with you. That just does not happen. It sounds odd, I'm sure, but none of us was taught how to communicate with our patients. We learn from role models. Some, like Daniel, are pretty good at finding good role models. Some of us, who will go unmentioned, namely me, maybe not so much so. So we're not leaving that to randomness. And again, our students in the audience can attest already in their short tenure with us how they're being taught to communicate with you, which is critical to their being empathetic in your training, in their training. So Yvonne, I know you get a lot of calls from hospitals, medical schools across the country with asking for advice on how to improve their Press-Ganey scores and a variety of other things. Can you just share with us what can helping physicians communicate? How does that better improve their Press-Ganey scores?
So first of all, I mean, the question is, can you teach a physician or a medical student to communicate better, more effectively, and with empathy and compassion? So that's the first question we always get, and the answer is yes. When we ask the audience or we ask physicians, it's always a split. Yes, you can teach that. No, you can't. You're born one way or the other. But the fact is, we've seen through our experience you can, and there has been a recent study. You know, this is a brand new burgeoning field. You would think, you ask anybody and they think their doctor's already been trained in how to communicate with compassion. And the fact is, this is a whole new field. I mean, it just got named recently, and a new book came out called Compassionomics, which is now naming this field. And basically, it's putting a framework around how to train our doctors to communicate. And what it does is, you know, now there's more programs coming about. So this study that just came out are 52 schools in a systematic review of training curriculum to doctors and medical students. And it shows that in the study that 75% of these showed an improvement in empathy and compassion. And if we ask any of you, are you empathetic? The answer would probably be yes. But what really matters is somebody on the receiving end experiencing that empathy, and that's called compassion. Compassion is empathy plus action. So we're training our students to actually show that empathy, and that's compassion. So in terms of improving Press-Ganey scores, how do we do that? And it's not as complicated as it seems. It's small little tweaks and changes. I'll tell you the story about one of the physicians I first met. I'll call him Dr. D when I first landed here. He came to one of the workshops that we did, and he came there with the intention of improving his Press-Ganey score. He was told that his whole practice wasn't doing well on their Press-Ganey scores, and he happened to be at the bottom of 25. And he experienced the workshop, 3-hour workshop, and I get a phone call that his Press-Ganey scores in the next round, he was now number 2. He was number 2 at the bottom, and now he's number 2 at the top. Now, I didn't create this, we didn't create this miracle. So I asked him, well, what happened? What did you change? And he said, well, first of all, I made sure that I felt more connected with my patient. I asked them their story. I made sure that they felt heard. And I did little changes like many of you are in the ER and it could take hours to get a test back from radiology, and you're wondering, of course, what's wrong, nobody's coming to speak to me. He'll send a nurse in to tell them updates, or he'll have a sticky pad and send them home with his, contact us if there is a problem. Little tiny changes, and connecting with stories and past experiences. And he said just those little changes brought him up. And I said to him, well, what did it do for you as a physician? What has happened? And he said, well, after a 30-year career in the ER, I'm burnt out. I'm exhausted. And what it did for me was reconnect me with my patients, and now I'm excited to go to work. So the feeling of can we teach this and can we improve scores is not as challenging and difficult as many physicians fear. And we're going to do that with our students. We're doing it right now to prepare them. And it really, in the end, is easier and saves time, and we have happier physicians.
Excellent. Well, I'm going to go back to some of the themes earlier on innovation and technology, and maybe it's linked to business models. So I'm going to kick it back to Wenji. As you think about transformation and experience, what dimensions of technology, either to improve access to care, improve diagnoses, and on are you seeing? What's really transforming the landscape today?
Yeah, I think there's two big areas in the next really 3 to 5 years, and then in the 5 to 10 year horizon, I think the clinical component will really come to bear, and I'll give an example of that in a minute. But in the 3 to 5 years, I think being able to improve access. So it used to be, in order to have medical advisors or get medical care, you had to go somewhere, right? And we all know with Teladoc, how many of your insurance companies have virtual visits available to you, right? About a third of the room. How many of you have used a virtual visit? All the students in the back, none of the people up front, right? Okay, being able to utilize technology to extend that relationship is, I think, a big piece. So whether it's virtual visits, which you've all heard about, or it can be little things, Yvonne, your story about the ER doc, we know that, we've known for years, really successful emergency room physicians from a press gaining standpoint oftentimes were giving out their cell phone number at the end of a visit, right? And saying, hey, if you need anything, call. And they would tell you, hey, I don't actually get called that often, but it's the fact that I would do it. Well, how do you then take that best practice and, in my role, be able to scale that? So this past year, Texas Health rolled out what's called hospital to home. So if you come into a Texas Health emergency room, you actually have access to an emergency room physician who practices in our hospitals for 7 days post-discharge, post your ED visit, free of charge, so that we can answer any questions you may have and ensure that you are on the road to recovery. So it's big things, and big ideas like virtual visits you hear about the Da Vinci robot being able to, the surgeons here sitting in Fort Worth and doing surgery on somebody, in either rural Texas or rural Estonia, right? So the ability for technology to improve access. I think the second is early detection, and that's coming and helping with early detection in workflow, clinical workflow. So we have had CAD, computer-assisted detection in radiology for a long, long time. The second read right by the computer pointing out areas that the radiologist should look at. The next step that's being implemented now and has been implemented for several years, and I think will explode even more, is for the computer not only to be able to see the areas and point them out, but then to be able to order the images in order of clinical priority, so that the radiologist says, the computer can say, hey, read these first, instead of FIFO, right? It used to be first in, first out, to say, no, take a look at these first. I'm going to order your reads in order of clinical priority. And that obviously has a significant improvement. And then when you look at how you use big data sets to really change clinical outcomes from a mortality standpoint, I just had the privilege of going to Hopkins Annual Biomedical AI Forum, where I learned about the Felix Project, where they're using large data sets to be able to predict and be able to find pancreatic cancer, which we all know is hard to detect, right? big killer. You don't find it till stage 4 later. Clinicians keep me honest. And they're able now to find that cancer earlier because of what they're being able to do with AI and machine learning. And so I think first is going to come the democratization and access, then improving clinical workflow and efficiency, and then a lot of these true clinical interventions are ripe and coming on the horizon.
So I'm going to ask Ben about technology and why the healthcare environment is so slow at adopting it. I'm going to frame it around the fact that 2 weeks ago, our students have a course that runs their first year called Future Accelerators of Medicine. And the future for them is not 2020. They think it is. Sorry, students. We set this course at 2030. And of course, none of us knows where technology is going to be or a lot of other things in 2030. But 2 weeks ago, we invited IBM and Watson to come to our campus, spend a day with our students. GE came another day. PCCI came from Dallas another day and worked with our students on social determinants of health. The Watson experience was our students were asked to design the office assistant for them in 2030. And I will just tell you it was fascinating because these students are not encumbered by any of the dogma of healthcare today. The IBM leader was overwhelmed at what he heard. I cashed that in and asked them if they wanted to name our medical school. I got a pretty serious pivot pretty quickly. So we're going to send out a release that Watson went to medical school. So our graduates, and not just this school, to state the obvious, are going to drive the role of technology in medicine. And they're going to lead it, and they're going to expect it. So my question to you, Ben, is why do you think the healthcare environment, you've just said that the Apple Store is loaded with apps for health and healthcare. Why do you think we're so slow in adapting relative to other industries? And is that a tough question? Because if it is, I apologize.
Yeah,
But I'm still going to expect you to answer it.
Yeah,
so.
I know. I was looking for the exit. Well, I think, actually, Wenji laid out all of the great positives around technology, and I think there are a lot, and we're constantly moving in the right direction. I think, I'll just try to bring in some of the temper, like what are the challenges, right, around technology. And so when we think about, I always try to simplify things. So I think about healthcare technology, I put it into 3 buckets. There's the digitization of the system. So we're just moving everything that used to be paper and manual into more automatic processes and digital. There's a bucket of technology that's around interaction with individuals, right? So you have wearables and you have apps on your phone and diagnostics that are very personal, and you're able to interact with the health system as a consumer, and the health system can interact with you, and that could be virtual health and things like that. And then the third bucket are the innovations, and that's where you get to the IBM Watsons and the assisted reading of X-rays and images and things like that. So what are the challenges for all 3 of those, and why are we not adopting them quicker? Well, I mean, there's a couple of weird things about healthcare. So one is we're the only kind of economic sector where technology actually raises costs, not lowers costs. And if you look at like what CMS does in terms of their projections of medical cost trend for the United States overall, technology actually adds. If you look in a lot of other industries, technology is actually reducing cost. So why is it that technology in the healthcare world often adds cost, not reduces cost? I mean, one is we have a very highly regulated industry, so there's a lot of hoops to go through. And the second is that the stakes are really high. This isn't like my algorithm didn't pick my favorite song from the Rolling Stones correctly in the right order. This is, did we get your reading correct, and are we able to treat you? So the stakes are really high. But let's go through those kind of 3 buckets, I laid out to get a picture of what the hurdles are. So when we think about the digitization, we've made incredible progress. So like 98% of all hospitals have an electronic medical record, and probably in the low 90s for the physician offices. But there are challenges with that because it can interrupt the workflow of how do clinicians work, how do people interact with patients, and so you get the check the box syndrome where now you're talking to your physician and they're just like working through their computer, check, trying to type, write things down, and they're not interacting with you. On the institutional level, we still don't have a lot of good trading of information and data, because now everyone they're starting to look at data as being valuable. And so instead of sharing data to create new discoveries, a lot of times people are hoarding data, or there are even kind of legal roadblocks in terms of like charging different organizations to get the data and things like that. So in the digitization, lots of progress, but we're now starting to unearth some of the challenges there that are slowing us down that we need to get over. In the consumer-related data, some of that is less regulated. So you see a huge explosion in things that are not very risky to individuals, like your heart, your exercise monitors and apps that are tracking your nutrition and things like that. And so there's been that's been a very a big area for growth. The challenge with that is that consumers, we all are collecting a lot of data, but the formal health system doesn't yet know how to receive it. So you may be taking your blood pressure every day and have a much more accurate count of what your life is like in terms of your blood pressure. But yet when you go to the doctor's office, are they comfortable just kind of getting the download from you or your device on that? Or do they want to take your blood pressure from that one little moment at that time and say, that's what goes in your record? So that's kind of the challenge we're still working out, is how do consumers that create and collect all of this stuff, how do they interact with the formal health system? And so that does slow down some of the progress we will eventually make when that gets connected up better. And then last but not least is around the innovation. And so that's when we start getting into things like machine learning and artificial intelligence. And the challenge there goes back to that risk factor. And that is, the stakes are really high. And so there's liability issues, like, is the algorithm responsible for an issue? Is the physician responsible for an issue? Is the company that sold you the software responsible for an issue? All of those things are being worked out right now, and I think they will eventually be worked out. Probably the answer in the near term is going to be all of this technology on the innovation side is really there to assist a clinician in making a decision, but it will always be the clinician in the end who makes the decision, at least in the near term. 10, 15 years from now, who knows? It may very well be you'll have a complete conversation with your Xbox, and they'll continue the surgery, and you'll be very happy with it. And then my son will finally have a job as an Xbox surgeon.
I love it. My next question is for Yvonne, and it's kind of set against the context of our mission here at the medical school, and it's to inspire empathetic scholars. And so I want to try to weave three of the themes that we've heard already together, and then kind of ask you to opine a bit on what that means as we look forward. We talked a lot about preparing physicians not for 2020 but for 2030. We've talked a lot about technology and tools and how those might affect things. And then we've talked about empathy. We've talked about some of the things, and Dr. D did to increase empathy and its transition to compassion. But some of those things were still very, very traditional: a handwritten note, a more discerned in-person conversation. But with the rise of technology and the need to prepare not for the now but for the next, how are we going to ensure that the importance of empathy on the way to compassion can endure despite the bits and bytes and AI and machine learning and all these things?
Ironically, I think the infusion of technology is going to make physicians change the role of physicians. Their role is going to be more about the art of medicine. So technology could take over diagnostics and treatments, but I argue it can't replace the human connection. And patients want to be heard, not by a machine, but by a human. Patients may Google, but then they're going to go to their physician and say, what would you do if this was your daughter? So it's more important that we train our physicians now to listen and not do what technology can do. So their role is going to change. Right now, almost 80% of primary care physicians miss the opportunity to show their compassion in a visit. Only 0.5% of surgeons actually take the opportunity to show compassion. So can you imagine how much harder it is to then have technology replace that? So what we're working on here with our students is one way of showing the compassion is don't miss those opportunities. Because if you miss the opportunity that's before you, how does that make the patient feel? All patients want is to be heard, and you miss those opportunities. So technology, I argue, can't replace that. In fact, I think it was you, Dean Flynn, who sent me the story from Kaiser, where there was a patient hospitalized who was being told that he was going to die, and the way they chose to tell him was they rolled in a computer screen, and the physician told them over the computer screen that you're going to die. So maybe some communication, like, I can see it helping with connecting with your physician. I mean, how many of you have waited days to get a call back from your doctor? So maybe through emails or texting, that would be more of a connection, so you're at least getting answers quicker. But it cannot replace things like breaking bad news. And so I think it's going to be a bigger part of what a physician's role is.
Great. Thank you, Yvonne. Ben, everything we do now, we know, almost everything, is global. It's no longer regional or national, but international. You just completed a large study, I believe with 8 countries, asking consumers what their biggest concerns were. Can you just share what your findings were and maybe compare and contrast then with the U.S.?
Yeah, and this was really interesting to us. So the subject that we were working on was social determinants of health. So these are the areas outside the traditional health system. So things like your nutrition in your community, your ability to have a safe environment that you can exercise and walk in. You could be pollution, transportation, all the things that are kind of happening outside the traditional health system, which actually affect our health to a great deal, our income, our education, our living situations. And so we were looking at an 8-country study we conducted an 8-country study around the world on what are different countries and health systems doing for social determinants, but also what are consumers around the world struggling with and what are their challenges. One thing that we found is that we may be starting to lose ground in terms of our overall health. So we've had these incredible lengthening of average lifespan in many, many countries around the world. We're starting to see that slow down in many cases, and there's the concern that it could actually reverse. And part of that is when you look at things like the obesity epidemic, which often leads to things like diabetes and other diseases. We see that around the world, whether you're in a highly developed economy like the United States or maybe more of a developing economy like in India, that these issues are plaguing the populace. One thing that surprised us from the consumer surveys that we ran was kind of these ailments of the modern world, which we kind of talk about, but we finally saw the data around. So we asked consumers, what are some of the biggest barriers for you in terms of having a healthier lifestyle? And at the top of the list for those that said, I'm having trouble keeping a healthy lifestyle, were things like lack of sleep, stress in the workplace and in the community, challenges with the use of technology, kind of the always-on world that we're in. And those are really starting to affect our communities and us as individuals. And that was the same anywhere around the world. Again, use of technology is not an issue just in the United States and Western Europe. It's everywhere. Everyone has smartphones all around the world that are always on, always pinging at them. Those things are affecting sleep. Those things are also driving stress. And so I think what it also brought to light that even here in the United States, we think of social determinants typically as something that happens that we have to address in less fortunate communities. And so there's a lot of like zip code analysis of where these social determinant challenges are, in terms of transportation and nutrition and things of that nature. But so that is usually thought of as like, well, that's the Medicaid population or the uninsured population. Now what we're seeing is, no, really, it's like every part of the population is dealing with behavioral health issues, brain issues, stress, and things of that nature. And I think that's a little bit of a change in terms of what we have to do as a society. And it means that we have to connect the health system up much more closely to the social service system. I think it makes it even more important that our physicians and clinicians are compassionate and they're having these conversations with people, not just why did you come here today, but also what's your home life like? Are there systemic things that are happening upstream that we should be helping with to create a better outcome for you?
Yeah, I wanted to follow up that with a question for Wenjie. So these global level insights, there's some common threads, maybe some variations. Can you apply that to the the very local market? Are you seeing a lot of the same things? Anything unique to the community that we serve?
I think you can apply a lot of it, and I don't want to echo what Ben said about the challenges people face and where we are in this moment in the healthcare system in the U.S., which is, I've had the privilege of talking with a lot of people in this community about what are the barriers to their health. And whether it's Annie, a girl from Dallas who, much like many of you in the room, did all the right things, got a master's degree, worked for several years, and then followed her passion and became an entrepreneur, started her own company, ran a very successful nonprofit consulting firm for 10 years, and took care of her family at the same time, because that's what strong, independent women do. And she not only did that, but then her dad got sick, had dialysis, and then during one of his dialysis events, eventually had a stroke. And she did what every good daughter would do, and she became the primary caregiver for her dad. And ultimately, because of that choice, she ended up having to sell her business, lost it, and declared medical bankruptcy. This is somebody who is probably very much like me, right? I did a lot of those same things. Much like many of you maybe have the same aspirations, but for that choice, is in a different situation now. And when I met Annie, I met her about 8 weeks after her dad had passed. And she had the courage to say to us, I look in the mirror and I don't know who's looking back at me every day. I don't know what I'll do next. But she also said, without hesitancy, I would make the same choice, the exact same choice over again, because that's who she is. And many of us in the same room would do the same thing. And I think about Annie a lot, because we need to solve the system for her, right? Texas Health Resources, we are a almost 5 billion organization, a nonprofit, faith-based organization in this community. We have to figure out a way to support Annie, who's, by all accounts, physically healthy, right? She's not utilizing the system. But all the things Ben said and all the things, right, it all connects. And how do we support her in a way so that she doesn't end up with physical manifestations and clinical diagnoses, but also support her through that journey. And by understanding members of our community who have that, I think is deeply important. And whether it's Annie or whether it's the dad in a suburb I met whose mom, they're both teachers, and their health plan changed where instead of a family deductible, and by the way, he has 3 boys. Anybody here have boys? You know that you end up, right, in the urgent care or ER a lot, right? He had a family deductible for a long time, $5,000, he figured it out, right? His plan changed, and now it's not a family deductible. He has to come up with $5,000 for each member of his family. Who has $25,000 lying around, right? And I met him in the springtime where he was actually making a decision. His family is entirely healthy, completely healthy. This is the economic problem we're talking about, right? His choice is, do I take my kids on a family vacation this summer and roll the dice and hope that they don't get sick in the winter, right? We're entering a big raging flu season. Or do I not, so that I have the money I need to take care of my family in case I need health care? That is a deeply economic problem that we need to solve. And we don't solve it by, just technology or just automation or just fixing the sick care system. We solve it by having empathy and by understanding what the needs in this community are and what are the things that we can do to solve those issues, because it's all of our issue. It's not just that person over there or that community or that zip code. These are people we all know and interact with on a daily basis.
So tough to follow the Annie story, but that's the task I've been handed. So I am going to go off script with Yvonne, which now, if she were being monitored, you would have just seen a few heartbeat misses.
I'm used to him.
So Yvonne, we've talked a lot about medical students learning how to communicate with patients, how to build, teach compassion, empathy. Is that enough for the physician workforce? Or, to reframe it, when our graduates go to their residency training program, which they all have to do to be licensed and see patients, is it also important that they continue this journey in their residency program? And I frame this, we went from global with Ben to very local for this question, in the sense that we have some GME residency training in this region, in this county, I should say, including world-class, nationally ranked family medicine training program at JPS. Robert Early tells me it's #1 in the nation, and just by sheer nature, I tell him no, it's #2. Just because if you know Robert, you just have to do that to him. But some of, is he here? I don't even want to look. Robert, you owe me a lunch anyhow, so there. Replace him with IT. So we also have some of our other very valued partners who are about to start on the journey of graduate medical education. So, Yvonne, do house officers need to be taught how to communicate, or is it good enough just in medical school? And then does somebody with a little gray hair, like maybe Mr. Early, is it too late for him to learn how to communicate? Take that one and run with it.
Yeah. Well, I mean, Stuart, you've told me often that if it's a hard sell to physicians with gray hair that they're not good communicators, right? Everybody thinks they're a good communicator. And yes, everybody can benefit from this training from medical schools on up. I mean, some of the skeptics say, we're going to train our students to be compassionate, and then they're going to go into the big, bad, ugly world and get beaten down and go back to their old tricks. I mean, that is, that's a risk we have, but somebody's got to be the change maker. And what I'm already observing is we're teaching our medical students differently than when we were in medical school, where if the chief of surgery does it this way, this is the way you do it. This is the right way. But I'm already hearing our students see patients from day one. They're in their clerk, they have these physicians that they are their preceptors, and they're already coming back and sharing in our debriefs that they like the way the physician did this. Maybe they would have done, the patient didn't receive it well. They're going in with a new a new vision of making their own choices, what works for them, but looking at how it lands on the patient, more importantly than this is the way the chief of surgery has done this all these years. So we're hoping that our medical students will withstand what is out there and make choices for themselves. It will help all of our physicians. And when I first started at the Alda Center, I spent half my time convincing people this was important. That's what half of my, I've given hundreds and hundreds across the country, hospitals, medical schools, and half of the time in my hour plenaries was convincing people that this was important, and audience breaking out screaming at each other that, is it important or not? And now, in a decade, we all know it's important. I don't even have to argue that anymore. So we are making huge strides. And to argue for our older physicians and our residents, for sure, should engage in this type of training. It's, just the awareness piece. Dr. D, I think the biggest light bulb for him was this awareness of it helped change his, and also, Press-Ganey scores mattered for his career, right? So that was the other driving force. But I think we can make big changes in residency programs and with our attendings. And why does it even matter to the physician out in practice? They think it takes more time, actually, to communicate with compassion. But studies have shown it actually saves time. I mean, you have all been in these experiences. If you trust your physician, you're going to open up and you're going to tell them more information quicker, as opposed to, I don't like this person, and I don't want to, so the visit takes longer. It takes more time to get the information you need. They're less compliant. Their emotional health impacts their physical health. We all know this. So it does impact the bottom line as well as a physician's practice. In terms of the healthcare system, one of the biggest complaints upon discharge from my previous hospital I was at was the doctor didn't let me finish telling my story. It wasn't, I waited 12 hours in the emergency room. I didn't it was all about being heard. And that was consistent. I've spoken at hundreds of hospitals, and in some way that rises to the top. I don't know if you've experienced that too. 87% in this book, Compassionomics, says that 80% of patients would rather have a kind and compassionate, and they choose their physician based on kind and compassionate over the medical care. Because if everybody I speak with, if we ask them, what do you remember most about your best experience with a physician, and we list it, right? And then we look at the list, and nowhere on that list was medicine. It was all about the connection. And that's because patients assume their doctors know medicine. That's their assumption. But what makes or breaks it is this connection. And as Dean Flynn said, it also decreases malpractice. There's many, many reasons why physicians should be conscious of this and want to improve their skills. I'm improving my skills every day. Everybody can improve.
So I'm disappointed in that question on two accounts. You handled it phenomenally. And Robert Early got to stand up and take a bow. So on that note, it's over to you, Daniel.
We've just been handed a couple of questions. So as we process this, I just want to maybe kick it to Ben to comment. Given generally speaking, we've been in a period of pretty robust economic growth nationally. Certainly the Fort Worth, Dallas metro area is, a nationally leading example of the strength of the economy in the last really decade. Or more. And so what that's really driven is really low unemployment rates, a war for talent in many respects. And, Yvonne mentioned the bottom line. So much of the bottom line is dependent on the talent that employers, regardless of industry, can attract and retain and propel in many ways. How are health and wellness benefits and this whole dimension of an employee's experience with their employer, how are employers thinking about using this to attract, retain, and propel their talent?
Well, first of all, that's exactly right. I mean, with the tightening labor economy, it makes a big difference in terms of how you recruit and retain employees. So, taking a step back, looking at the employers themselves, I mean, U.S. businesses, they insure 155 million active employees and about 180 with retirees. So they're actually our U.S. businesses are insuring more people than Medicare and Medicaid combined. They're the largest insurer as a whole when you put it all together. And they've got wants and desires too, right? And they've got frustrations. And so they're frustrated that, average medical cost trends going up almost 6% a year, which is 2 to 3 times general economic inflation. They're frustrated when their people have to take off work and it's not, they're sitting in waiting rooms and things like that. And they're taking action. Some of the larger employers are saying, we're going to provide our own primary care system for our employees. We're going to provide work site clinics or near site clinics for them. So you see examples of that from out in the oil patch, where one of the attractors is we'll get a trailer out there with doctors and nurses in there. None of you all graduating will ever work in a trailer in West Texas, don't worry. You work right here in comfortable Fort Worth. But that's one of the recruitment retention functions, is we can actually provide healthcare where you are. But it's not just kind of in the oil patch that's happening. It's also at companies like Goldman Sachs, where they have employee clinics. They're providing things like dermatology and cardiology and mental health services, along with primary care, with the idea being we want to satisfy you, we want to help you have a better experience with the healthcare system. We want you to, be at work more, obviously, and be healthy. So I expect that we're going to see more from employers around this, especially the larger employers who have that infrastructure that can do that. They know that when it's a tight labor market, you got to have a differentiator. And if it's not going to be kind of the salary and bonuses and things like that, there's a whole nother area of benefits, and can they make it more convenient for you and easier. And the last thing I'll end with on that is there's actually kind of a compassion part to that as well, because one of the big dissatisfiers is navigation of the system. No one helps them kind of pull it all together. So we see employers now starting to actually pay for third-party companies that come in, and they're like the concierge between their employee, their insurance company, and the medical system. And they're there to help you navigate, get second opinions, figure out costs, and things like that. And so in a weird way, it's almost like they're paying extra to have someone that's compassionate in terms of helping you walk through the system, be a part of that as well.
So what you may not know, but I know in very big font behind you is a clock. And I'm notorious for running over, and I don't think we have until 10. So I'm going to throw a jump ball up, but you have a minute and a half, whoever takes it. What's the next biggest change coming at us for patient engagement? You have a minute and a half. All right, I stumped the pen.
Okay, well, I'll just jump real quick. I'll only take 30 seconds, so I'll give the balance of my time to Wenji or whoever wants to take it. I think, in terms of patient engagement, it's around virtual health. And I don't think we've seen exactly how far that is going to go. So, I think some of you raised your hands in terms of having a virtual health visit. What was interesting is not many of you raised your hands when Wenji asked you if you had that as one of your benefits. I bet you do actually have it as one of your benefits, and you just don't know it, because about 80% of employers in the United States are now offering telehealth, virtual health visits as part of the health plan. I'm very curious to see what that means for overall engagement in terms of like managing things like chronic disease, doing more things for health and wellness over the next few years.
I just want to jump on what we've already said, but again, patients now are in a different place. It used to be he or she's a terrible communicator, but a great doctor, and I'm going to, wait 10 months to see that doctor. Yeah, I think that's the biggest change in terms of communication. Patients are going to be expecting now that their doctors connect and communicate with them. At least that's hopeful thinking that from our perspective.
So I'll round it out. We always talk about, changes being people, process, and technology. So Ben talked about the technology part. Yvonne talked about the kind of people part. I'm talking about the process part. I think one of the biggest changes that's going to be very difficult for most of us in the traditional provider world to swallow is the change in how the care team is configured and how they work together. Because there is a huge physician shortage, right? There's a huge nursing shortage. There's a shortage general. All you boomers out there retiring and living your best lives. I'm so jealous, but it leaves a big void in the workforce, right? So you have all these technologies that can enable these things, but in order to optimize the technology and order to optimize the navigation experience, we actually have to change how we care for patients. And what is the role of the primary care physician? What is the role of the nurse? What is the role of emerging roles that are more focused on social determinants and that whole person, right? What are the care options for Annie and her dad not just for Annie's dad clinically, but taking into account their family situation. What were the options for them? So maybe he could have had the same clinical, or better clinical outcome without her having to make the sacrifices she did. Requires us to change how we deliver care and who is on the team and what they do. And I think that is a fundamental change that will be difficult for all of us.
Great. Well, I want to thank everybody, but I want Daniel to close here if you would, but thank you all.
Yeah, what a great conversation. I think it's a beautiful way to end on those 3 big innovations, again, that are not just defining the now, but the next. Thanks for all of you for investing of your time and your insights and building community. It's a terribly important topic, and it's really up to us to continue to lead. Thank you very much. Have a great day.